Hello, everyone. Thank you for joining us today for the second in our series of webinars on the food, dining and nutrition in residential care. My name is Janet Anderson and I'm the Commissioner of the Aged Care Quality and Safety Commission. And it's my pleasure to welcome you all here today. I'll start by acknowledging the traditional owners of the lands on which we're meeting around Australia and paying my respects to elders past and present, and also to any Aboriginal and Torres Strait Islander people who are with us for today's seminar. Today we're discussing good practice in food, dining and nutrition in residential care, as I said, and I am delighted to be joined by three people who know a lot about this. There's Dr. Melanie Roth, who is the Chief Clinical Advisor in the Commission, and then we have two people from Whiddon, Michael Monteleone, who's the General Manager, Experience and Retirement Living, and Sharon Fletcher, who's the General Manager, Quality, Care and Compliance. Now, we've allocated 60 minutes for this webinar and it is being recorded, so there will be a copy of the recording available via our website. Dr. Roth is going to start us off with an overview of the key principles of the dining experience and consumer choice. And then she will be leading a conversation with Michael and Sharon from Whiddon through a range of experiences that Whiddon has had as it's looked to the consumer experience of food and meals and dining and has reached for excellence, I would say, in this regard. If you have any questions, please don't hesitate to submit them to us using the question mark icon. We'll field as many of them as we can in the course of the webinar, and any we don't get to will be the subject of a Q&A that we'll publish on our website subsequently. And also, if you stay on till the end, there is a survey, an online survey, which will pop up immediately after the webinar, and we would love you to complete that because it gives us a way of understanding how you have found the webinar and also gives us some tips as to how we might get better at this and use your feedback to improve what we are able to offer you. We're also seeking to ask you and get your feedback on topics of interest for your organisation in this domain, in improving food, nutrition and dining in your service, and also any information you have on the resources that you would like to see us release, or indeed feedback on the resources that we've already made available. Now, just before I hand over to Melanie, I'd like to make a couple of opening remarks. As many of you would know, the Commission has had a particular interest and focus on food, nutrition and dining in residential care for some time. And one of our aims in this work is to support you, the providers, to build staff capability to identify and act early on areas that are impacting eating by residents. And we are simultaneously keen to support consumers to understand how they can identify and raise concerns about food, meals and related issues, and to collaborate with staff and with providers, obviously, to solve problems and to engineer improvements in that experience. Now, our expectation is that through the work that we do with you and with consumers, we will contribute to reducing the risks of malnourishment and unplanned weight loss, and also provide further improvements or impetus to the improvements that we're seeking to drive to residents' quality of life through the meals that they have in residential care. We've already produced a range of resources, including fact sheets, posters, other guidance material. It's available on our website already. If you haven't checked it out, please do. It covers 4 particular areas impacting eating. First, the dining experience. Secondly, consumer choice. Thirdly, oral health. And fourth, swallowing. And those resources are supported by online learning materials in our Alice platform, again, available to you via registration on our website. As always, we're focusing on risk, but we're also very interested in best practice or even in good practice. And we want to be able to share that more widely. So if you have some ideas or success stories, please let us know. Now, without further ado, and of course our Whiddon guests are going to be leaning in to that story of lessons learned the developmental track that they have followed in order to improve their consumers' experience of food, nutrition, and the dining experience. Without further ado, I'll invite Melanie Roth to speak to us on some of the key principles of the dining experience and consumer choice. Thanks, Melanie.
Thanks very much, Janet. It's certainly my pleasure to be able to talk a bit more about food, dining and nutrition today. It's so important to get this as good as it can be for aged care residents. So I'm going to talk briefly about three key areas introduced in the first webinar. These are food and governance, choice and the dining experience. Now, there's currently a review of the aged care quality standards, which I'm sure most of you are well aware of, and these include a focus on areas of concern identified by the Royal Commission. And these are provider governance, diversity, dementia, food and nutrition, and palliative care. And many of those, as you know, are interlinked. A draft of these revised quality standards is available on the Department of Health and Aged Care's website for review and for comment by the 25th of November. So I'm sure most of you have already looked at these, but if you haven't, please visit the department's website. The draft revised standards include actions that good providers are already doing. Draft Standard 6, Food and Nutrition, is new and it's fantastic, and it has 4 outcomes. You can see those outcomes on the slide. Each of these outcomes has a statement and a series of actions for providers. For example, the draft actions that accompany outcome 6.1, partnering with older people on food and nutrition, indicate that providers need to implement a system to monitor and continuously improve the food service in response to satisfaction, intake of food and drink, the impact of food and drink on health outcomes, and contemporary evidence-based practice for food and drink. Now, this speaks directly to the governance of food, dining and nutrition and how it is managed within an organisation. So I'm going to start with food and governance, because good food, good dining, good nutrition comes from the organisation's top. Improvements, initiatives and innovation that is supported at the most senior levels of the organisation are more likely to succeed and be sustained. And this is large things and sometimes very small things that can make a significant difference. We at the Commission sometimes see that a board of directors or senior staff will refer to weight loss or weight gain as the only or main marker for food and dining. If this is all you look at, you'll miss so much of what's important. If someone reduces their eating, it can be for many reasons, and this can be detected and fixed long before they lose a significant amount of weight. Also, weight does not equal nutrition, and weight does not equal quality of life. And if you want to understand the loose linkage only between weight and nutrition, just speak to your dietitian who'll explain it to you with great enthusiasm. We need to broaden our focus to look at the experience as a whole. And the draft quality standards really highlight this. So I'd like to challenge you to really reflect on the food governance arrangements you have in place. This is the systems and processes and who is responsible for them. It also involves managing education, monitoring and oversight. So in your organisation, what are these systems? Are they in fact clear, and do they exist? What does your current system tell you about individual resident needs, preferences and satisfaction with food and their dining experience? And does your feedback and engagement really tell you this? Does it include all residents or only those who can complain, complete a survey or communicate with you? Does it include any attempt to understand the preferences of people who might be living with dementia or have other reasons why they can't communicate with you easily? Are you understanding and monitoring the links between food, drink and health? What does your quality indicator data tell you? And not just the weight loss quality indicator data, as you will hear. Are you confident that your governance arrangements ensure resident meals are prepared and served safely? Is what is on your menus actually what is on the plates? Have you actually been to see the food recently? Does the food that's served get into the mouths of each person? Do staff detect and report if a person is not eating well, and why not? And can you introduce any improvements and sustain these improvements? How do you measure success? What will you measure and how will you measure it? How will you listen to consumers? If you haven't already viewed the draft revised quality standards, please do so and think about what they mean for your service. I also encourage you to provide your feedback during this consultation period, and you'll find instructions on how to do that on the department's website. A very important aspect of a provider's governance system that impacts on resident health and wellbeing is what systems and processes there are to support and assure residents' rights to make choices about their own food, drink and dining experience. Which brings me to choice. Choice really matters. It's a human right, and this right does not change as people age or move into residential aged care. One of the things people fear most is loss of autonomy and the ability to keep doing and eating the things they love. Delivering truly person-centred care, where each person is treated respectfully as an individual being, including getting to know each resident and their preferences. For example, knowing where and when they like to eat, who they like to dine with, how often and how much they eat. What about people who can't tell you this? How do you find out, observe and record this? Choice is fundamental to person-centred care. We know that people who have genuine choice are more likely to eat and drink well. This helps to prevent unplanned weight loss and malnutrition. It reduces the risk of illness and injury, improves quality of life, and it increases satisfaction with their aged care experience. If that alone doesn't convince you that you will see results, you need to think about resident satisfaction, your quality indicators, staff morale and retention, and your reputation. The revised quality standard 6, food and nutrition, includes an action for providers to implement a system to monitor and continuously improve the food service in response to the older person's satisfaction. Aged care providers and their staff are legally required to provide informed choice to residents and to respect those choices. So the detailed draft of the revised quality standards makes all this clear. Sometimes, of course, there are risks associated with choice, and every smoker knows this. Some residents may choose to accept the risks so they can eat the food and drink the drinks they want. Some of these risks are what they've decided and chosen to do long before going into aged care. And we'll be talking more about risk in a future webinar. Boards and senior managers, however, should satisfy themselves that residents are supported at the service to make genuine choices, including where there are risks attached to the choices. Conversations, advice and decisions need to be recorded. Remember, there are risks associated with not allowing choice. People who aren't allowed to choose tend to eat less or stop eating altogether or stop drinking sufficient amounts, with a rapid impact on their hydration, their weight, their frailty and, of course, their quality of life. Choices must, of course, be reasonable and practicable for the provider to deliver. I can't ask you for lobster 6 times a day with an expectation that that's reasonable. Most people's food choices, however, are reasonable and achievable. So lastly, the dining experience. This is a combination of the food and drinks provided, the service, the company, the environment and the atmosphere. This experience impacts on a resident's quality of life and wellbeing every meal, every day. Think of a bad restaurant experience that you've had, and that can be due to many components. And do some of these things actually apply to your service? Residents who enjoy their dining experience are more likely to eat in the dining room. They're more likely to eat and drink well and with pleasure. There are many ways to provide excellent dining experiences in aged care. What works well in one service may not work well in others. A focus on the dining experience means making meal times about food, drink and socialising rather than a chore or part of a clinical task. Are staff actually there during meal times, or are their own meal breaks at the same time? If people need assistance with eating, is the carer on their phone or talking to another staff member, or mixing food into a mush and mechanically feeding someone, rushing them, ignoring their presence? Or are they explaining food to the resident and talking with them meaningfully and treating them with dignity and kindness? Assisting someone with their eating is a human contact opportunity that many crave and miss, and many providers miss this as an opportunity. The draft revised quality standards explicitly covers enjoying the dining experience. The 4 actions related to this outcome speak to the provider, staff, consumers and the dining environment. The Commission sees a wide spectrum of practice in relation to all aspects of food, dining and nutrition. We know that wonderful dining experiences and food that suits the residents' goals, wishes and needs absolutely can be produced. Dementia Australia has also got some really good reading material to help support the dining experience and nutrition for people living with dementia. We see how little things can make a big difference and how enabling staff to notice and change even little things is important. This starts with senior managers and board members to understand why food, dining and nutrition is so important. We're not just saying it. It really does make a demonstrable difference. To decide that it matters, to decide that it's a priority for your organisation, and to commit to ensuring that oversight, resource allocation, attitudes and culture have their settings from the very top. Go and actually see what's happening through the eyes of yourself as a future resident. We at the Commission want what the government and public expects, and most of all, we want what consumers want. Food and dining has a profound influence on resident satisfaction, health and quality of life, and residents are very happy to talk to us about these things. So today we'd love to share with you one provider's pathway to change. They're not alone. Many of you will have your own innovations or changes and stories to tell, and indeed we've heard some of these, but please let us know. We really want these stories to be ordinary and common. Thanks, Janet.
Wonderful. Thank you, Melanie. A lot of information conveyed there, and I say again, this webinar is being recorded, and maybe you want to revisit it online just to check that you've fully taken on board everything that Melanie has just shared. It's a cornucopia of information there, and there's more to come. Before I go back to Melanie, invite her to start the conversation with Sharon Fletcher and Michael Montaglione. As the conversation unfolds, I want you to think about your own journey in delivering good food and nutrition at the services you manage or where you work. And you might find that some of the conversation that you're about to hear sparks an idea for your service. So open yourself up to that possibility. It may be that you feel you're doing a really first-rate job already, or it may be that you have something further that you can gain from this conversation. Whatever pathway you take, I do encourage you to reach beyond compliance with the standards when it comes to food, dining and nutrition. As Melanie said, we need to look for ways for providers to truly embed the consumer experience, well-being, the quality and safety in all aspects of organisational life within the services you operate. And that's what we would be hoping that every single one of you is reaching for. And that's what I'm confident that Whiddon is reaching for. So without further ado, Melanie, I'll come back to you and you can proceed with your conversation with Michael and Sharon.
Thanks very much. Yes, I might start, Michael, with asking you to set the scene for us and tell us just a little bit about Whiddon, your locations and the services you provide, what sort of provider you are.
Thanks, Melanie, and good afternoon, everyone, and thank you for joining this webinar today. My name is Michael Montaglione. I'm from Whiddon Aged Care, a not-for-profit organisation. We have 24 regional and remote locations across New South Wales and one in Queensland with over 2,000 residents, and we play in the, obviously, residential aged care space as well as community care and retirement villages. We have a mix of older homes and newer homes, some based on our initial model of care and some based on our new model. We have the same staffing challenges as I'm sure all of you are encountering at the moment, with many vacant shifts, lack of talent and lack of people applying for roles. We have homes that cater for as little as 8 residents out in Burke, up to 500 residents at our largest campus in Sydney and Glenfield, where we've got 500 residents. Our homes are very much the same as any regular provider. Some homes have food cooked in a central kitchen where we distribute it to a couple of homes. We have a cook chill model in one home, but most of that is gone now. And dining rooms with no serveries, where there's a visual food driver like hot food on display. But we're redesigning homes as we go.
Thanks. You have a mix of services then, and I'm sure there are many providers in this webinar today that can relate to some or most of the characteristics you've described. Today, with our focus firmly on food, dining and nutrition, can you tell us about some of the changes you've made at your homes?
Thanks, Melanie. And yes, look, over the past several years, we've really focused a lot on food and dining and nutrition. And today I'll talk mainly around 4 main initiatives that we've rolled out and continue to roll out across our homes, 3 of which require minimal funds, some no funds at all, and 1 which is more of a larger CapEx redevelopment project. The 3 requiring minimal funds are around the first being an all-day dining menu and a supper focus for our residents. What we call our foodies group meetings, which is once a fortnight with our residents and family and friends, where we discuss menus and what's coming up, but we also talk about what are the things they didn't enjoy about our meals in the past, and cooking clubs. So very much getting an interactive facilitation of food with residents and getting them involved and really getting them as part of our food teams. And then the larger project, which requires investment, and that's what we call home-style kitchens. Firstly, I'll start with our all-day dining menu and our supper menu. So the all-day dining menu was developed mainly for 2 reasons. Residents requiring food once they return from an outing, or maybe from hospital or any other event where they weren't actually available for the set dining time. Residents' ability to eat when they want and what they want. We created this menu in conjunction with our residents and placed their favourite items on the menu. This really helped with a couple of things. Choice being obviously a huge one. We know that we're not going to please every single resident at every single meal period. So it was really important for us to be able to innovate and come up with a way that we could actually please our residents, or at least offer more choices than what was actually available. And it really opened up availability of food for our residents. So what we found was outside of meal periods, obviously there's limited food available. Having this all-day dining menu really allowed and made it available for residents to choose meals that weren't just a snack. And then focusing on our supper menu. So we found a need, and Sharon will talk a little bit about this later, but we really looked at why we need to develop a menu or a different offer in response to a few flags that were raised around falls and wandering. We saw our supper menu was a real need to be something that was more substantial in the evenings for all of our residents, something that had really high calories and that really helped with better rest and overall better sleep. Our menu included high-calorie thick shakes, soups and porridges, and we consulted with our residents around, well, what do they want and what time do they want to have their supper? We know that there's a huge gap between when they are having supper or even their main meal for dinner and then the morning when they wake up. The second initiative was really centered around resident choice. And I'm quite big, and Whiddon is really big on delivering what our residents really want. And we always have the philosophy around, well, why would we cook something that a resident doesn't want to eat? So our homes on a fortnightly basis, our chefs sit with our residents. Everyone is invited, including their families. And we talk about what the menu is going to be for the next fortnight. Now, we also talk about the previous fortnight, and we're really, really big on making sure that if there is something that residents don't like, we highlight it, we talk about it, and we make sure that it's something that we either don't do or we change for the future. We go over every menu item that's on the menu for the next fortnight, and we change things. We change literally the protein, we change the cut of meat, we change the kind of sauce. We change if the sauce is on the meat or if it's on the side. It is really up to them. And what we've seen is a couple of things. We've seen participation in dining rooms go up substantially. We've seen a huge reduction in waste because residents are actually eating the food. And that's obviously amounts to dollar savings as well. But what we're really seeing and what's really exciting is the interaction of our residents with each other and with the staff, all based around because the food is something that they actually are enjoying. The third initiative is our cooking club. And this is very much driven by our residents. We were looking at what activities we could do, and then we were thinking about, well, how do you make an environment very much like your home, and what are the big things that you do at home? And obviously cooking is a huge part of everyone's day, and it's no different for our residents. So we asked residents from all over Whiddon to submit their favourite recipes. We had hundreds of recipes submitted, and that became our cooking club. So we selected recipes that were cooked on a weekly or fortnightly basis. The residents came together. There was a little bit of investment in around, buying knives and buying chopping boards and all different things. And we bought little induction cooktops, which were $50 each from Harvey Norman. And we made it very much an activity, residents getting together, cooking things that they liked. But the exciting thing was very much around being together and obviously cooking something that meant something to them. The fourth initiative is that of home-style kitchens. So a few years ago, we were looking at what our model was and how do we change that environment. Now, at Whiddon, like most providers, most of our homes have the older style serveries. The servery that's in a room has bain-maries, and residents can't see, smell, or at least choose by looking at what the food is that's available. It really does, that environment does reduce choice to residents. It's something that we all have to deal with, but there are ways to get around that. One of the things we looked at, though, was retrofitting our serveries, what we call serveries, into a home-style kitchen, which meant removing walls and putting in a beautiful house kitchen. All domestic appliances, nothing commercial. We've just completed this at one of our largest homes, where there's 4 residential aged care homes on this one site, 14 dining spaces, which have all been transformed. And we've got from as small as 15 residents in one dining room up to 80 residents. The reason I'm saying this is because it is relevant that you're not going to be able to pull apart all of your homes and put in dining rooms everywhere or additional dining rooms. So we looked at, well, how do we accommodate an 80 resident dining room with this model? And we've looked at the different ways of building them. And in some of these areas, we've got 2 kitchens combined in that area for 80 residents. So there's definitely an investment involved in this initiative. But what I would say is that when renovating an older style home, adding extra wings to a home or building a new home from scratch, this type of dining creates both a home-like feel, but also inclusivity for residents. From an outcomes perspective, where the feedback's phenomenal on things like as simple as the toast is hot, the toast is crunchy. The eggs, we cook eggs to order with all of our residents now in these homes with home-style kitchens. They can see the food being cooked, they can smell the food being cooked, and it's making a huge difference that they're able to choose based on vision and smell rather than just what's shown on a menu.
Thanks very much. There's just so much in that. I think, yes, it's really, really provocative. Before we talk in more detail about the dining environment, can you tell us, Sharon, maybe you, how you got residents involved in these changes?
We have been working with our consumers for a long time and have had consumer-led foodies groups for a really long period of time. It was this partnership that really gave us a lot of insight to making meaningful change. And this is where the concept of the all-day dining menu was born. Refining these menus also started with these foodies groups. And now our menus, they are basically a scaffold which is built on by consumers each and every fortnight. So they are receiving the food that they like and that they have requested. We also have our annual survey results and have found that these have improved dramatically over time as a result of these initiatives. Now, every time we have a foodies group, there's less complaints within those foodies group meetings and much more collaboration and discussions about what's going on and what changes they'd like to see and you know, what they really enjoyed that's been served to them in the last few weeks. So it's been a really positive experience for everyone.
Yes, truly a win-win situation if you can get that right, isn't it? Michael, we spoke earlier about person-centred care and, you know, absolutely it is so important. If you can get that right, quality in many other areas will, of course, follow. So I'm really interested in hearing a bit more about the Cooking Club because it's a working example of person-centred care that supports genuine choice and engagement. Have there been any other benefits that you can talk about, such as maybe cultural inclusivity, cultural issues?
I think the good thing about the cooking club is that it's 100% resident driven. It's a time for them to gather and exchange thoughts over food, and it's really all about food being cooked, and it's ready for the next meal period. So all residents get to actually try and see what other residents have potentially cooked, and it's something from their cultural background. So I think from a cultural diversity and inclusivity piece, we have many cultures and nationalities within our homes. The cooking clubs increase that cultural diversity through food. Residents cooking and trying foods they've never have experienced before. But it also has given many residents a proud moment of showcasing something from either their past or their heritage. And just to add a little further to cultural diversity outside of the cooking club, all of our residents across our homes consulted with around their background, and if there are special meals that they would like us to have made and set aside in the event that they don't like something that's on the menu. Now, this can be cumbersome because obviously having the freezer space to hold these kind of frozen meals ready in case someone wants them can be large. But what it has done is it's really allowed and helped our residents to keep their culture and heritage rich.
Thanks. I'm just interested in why it became important for you to look at food and really take on this whole process. What Sharon prompted you to go on this journey of review and change? If you can go back to how it started.
Sure. So initially what had happened is we had filtered information up to our board and specifically about falls incidents. The board were really keen to address this and requested that we have a review of our current falls prevention strategies. And additionally, at the same time, the board were also very keen to improve our dining services. Initially, I don't believe that they saw these two things as a link, but operationally we did. We wanted to work smarter, not harder necessarily, but what we really wanted to do was make a difference for consumers. So by linking those two projects, that was really where the concept of these projects began.
So you really started identifying issues that you wanted to address and then really progressing to how you might go about that in what sounds like a relatively or a very creative problem-solving approach. But can you tell me how you looked at the problem from maybe a more clinical perspective?
Sure. So initially when we looked at our problem, we started to look at falls and we found many falls occurred in the morning. We then looked for all possible contributing factors to the falls, and we included things like sleep, use of medications in the 12 hours prior to the fall, food intake, how well people were eating and drinking, weight and frailty, and behaviours. And what we found was that many of our consumers were on a vicious cycle of falls, nocturnal restlessness, receiving either night sedation or another type of antipsychotic medication, sleeping through a meal, having decreased oral intake and a decreased weight. And we believed if we could break this vicious cycle, we may see benefits. We then took a deeper dive into sleep disturbance and looked for alternatives to pharmacological interventions. And this was really a back to basics approach. We didn't do anything high tech. We took the approach and the thought that if consumers went to bed with a nice full tummy, that they would sleep better, and we may see benefits in other areas. We initially started with the supper offering of a high-calorie shake, which had anywhere from 300 to 400 calories in each and every shake. We had a target list of consumers that we felt that would benefit from these shakes, but we also offered these to many other consumers. We've provided some basic education to the staff, so they had a great understanding of really what we were trying to achieve. And then we empowered them so that they could see what difference that they could make. If there was someone that they knew that wasn't on our target list that they thought would benefit, they had full freedom to run with that and serve those shakes to those people as well. We found that for some consumers that these simple steps did exactly what we had anticipated, which was they slept better. They were more alert in the mornings. They did not sleep through meals. They could eat and drink more at their usual meal times because they were well rested, and falls started to decrease. We stabilised weight loss for many consumers. We decreased the use of supplements, and we saw a decrease in the number of falls. We were also able to start reducing the use of medications used at nights for consumers who were experiencing sleep disturbance.
You've given really clear examples of how going back to the basics can make a fundamental difference with so many flow-on effects that in theory they should be there, but you're telling us that in practice they really, really are. One of the ideas you mentioned earlier, Michael, actually, that seemed particularly good for those who have irregular sleep patterns was an all-day menu and supper menu. It sounds challenging though. What were some of the barriers to implementing this? For example, how do you manage the cost? And do you think this would actually be easy for other providers to do?
So it's interesting because when we proposed to do this all-day dining menu, they were the exact questions that came up from our board and our executive. And to begin with, we did a trial to see what the impact would be. But what I will say from a cost perspective is that the cost of your all-day dining menu will be very much linked to what how your daily menu performs as well. So from our perspective, we've seen nothing more than a 5 cent per resident per day increase in our average food costs from a per resident per day perspective. But that is clearly linked because our menus are driven by our residents in our foodies groups, and there hasn't been a huge need for any kind of substantial meal overnight or even outside of our meal period. What we are seeing is that they're using it more so for snacking or changing their preference during a main meal service. If you are seeing higher costs with an all-day dining menu, the first thing I would look at is your regular menu, because generally it would mean that potentially there's food on it that residents aren't enjoying. One of the largest barriers, and I'm sure everyone's thinking it, is how do you implement this, especially from an overnight perspective. And just to be really clear, we did not add any catering staff members to facilitate this all-day dining menu. We, overnight, our nursing team look after this. Now, from what does that mean for a nurse? Of course, if there is going to be an order for a main meal, then there is some preparation involved. Now, our meals are frozen, so they are reheated. But what I said to them was, the way we sold it was, well, if a resident was hungry now, what would you do? And all of our nurses answered, well, we would get them something to eat. So it was very much around selling them, well, it's the same thing. We've just formalized the process and made sure that the food that residents are actually wanting to eat is available. The uptake of the hot food overnight is absolutely minimal, but we rest assured that if a resident was hungry or did return from hospital or did return from somewhere, that food is actually available, and it's not just a muesli bar and it's not just a packet of chips. The main thing I would say is that you need to sell the benefits. We know our team members want to give great care, so draw on the why of this rather than the why not. We gave really good training to our overnight nurses around temperature taking and food safety, as well as formalizing where all the items were located. And in hindsight, we actually made it easier for them. And the feedback has been that it's actually easier for them to facilitate if a resident wants something to eat, because now they know where the food is and they also know what's available for residents.
Thanks. And now going back actually to another of your initiatives was the introduction of home-style kitchens. Why do you think this has actually made such a difference?
So I think, as we all know, and again, I'm sure everyone here can relate, in your normal home where you live, a kitchen is such a central part of your home. It's where, it's one of the most used areas. It's where people meet. It's where people talk. And we know that food brings great togetherness. When residents move into residential aged care, it's one of the largest aspects of their life, which is generally removed. And that's quite a hard thing to deal with. So the home-style kitchens really ticks a few boxes. Food can be seen and smelt, which creates appetite and hunger. Residents have the ability to choose based on sight. Now, it's great to, write this fancy menu that has all these fancy words, but when you get the food and it's not what has actually been, said is on the menu, that has an impact. So they're actually able to choose based on sight. Staff availability is dramatically increased because there's no longer a separate part of the home where a servery is. They are actually in the dining room the whole time. The working space of our team is the actual home-style kitchen. Activities like cooking clubs as well as food preparation can be done in front of residents. So we have our chefs coming out into the homestyle kitchens outside of dining periods, and that's where they create and chop up carrots and make sauces and soups and cook lamb legs in the ovens. And the residents are there and they're watching, and they actually get involved sometimes, which is really good. It creates moments of interaction between residents' families and as well as the team. But most of all, it looks and acts just like a kitchen does in your home. And I think one of the big and really exciting parts to this is that we actually encourage our residents' families to come in and cook for their loved ones if they would like that, especially if it's something that their loved one is missing.
And just really, really briefly, if you can, how did you find that you were able to bring the board along with all of this? How was that experience?
So look, we are extremely lucky at Whiddon that our board, CEO and deputy CEO are wholeheartedly committed to food and what we call the Whiddon experience. Whiddon, like all businesses, should be looking at an ROI. It would be silly to say that ROIs aren't necessary. It is, to be sustainable and to continue operating. But we also look at what I like to call an EROI, which is the experience return on investment, because it's just as important, but obviously it needs to be financially available. To begin with, there was reservation around these kitchens because they had never been done before. Remembering that our first homestyle kitchen went live just over 4 years ago. There were lots of board submissions, role reviews, commercial kitchen reviews, workflow reviews, as well as discussion with residents and families. And to be honest, there was hesitation on all fronts. There was a reservation around the risk of these kitchens, residents hurting themselves, the kitchen not being able to be locked up, etc. All of which have now become the reason why we do it. Not because it's risky, but because a lot of the reason why not has become the reason why we must do it. Creating a home, a space that's relevant and inclusive and normal. We have these homestyle kitchens in our memory support homes, or a dementia unit, as most call them. And as they're having a great impact in creating great outcomes for our residents. As we all know, residents in dementia units, we see them pacing. We're seeing residents that used to pace, they're now in the kitchens and they're wiping bench tops and they're putting glassware away and, you know, they're putting crockery away and they're being involved. So it's actually having some great benefits, and it's about back to your board and your leadership team.
It's so interesting that it's become, what you're describing is it's become part of your overall behaviour management strategies, actually. But for people who are listening today who are not going to be able to renovate their dining rooms in the foreseeable future, but they're inspired by what you're saying anyway, do you have any advice for things that can be done that would take them part of the way reasonably cheaply and easily?
100%. And in fact, again, just so we're clear, most of our services don't have the homestyle kitchens. We're probably at about 40% of our services that have this new style. What I would say is to be able to have a dining experience that's relevant for our residents, think about what it's like in your own home. We create a similar effect of these homestyle kitchens by taking portable induction cooktops into a dining room and having the food on display. Residents can see it, they can smell it, they can hear it, and that's made a huge difference. So for a very low investment, we're talking, $200-300, you're able to transform a small part of your dining area with this innovation. Taking desserts into the dining space on a trolley with the chef or catering team member, wheeling it around and offering the item to residents based on the visual. It's inclusive and it allows for choice based on more than what the menu is actually saying it is. And again, taking residents into your commercial kitchens, why not? Show them what you're doing. Get them to come in and give their opinion on how you're doing it. Get them involved.
Thanks. Fantastic advice. Really, really, I'm aware that there's just so much to say, and we're getting towards the end of my formal questions to you. But Sharon, I'm quite sure that there'd be people listening who have many residents living with varying degrees of dementia, who are just having flashing lights about risk. And yet you're telling us very clearly that you've included this approach to all of your residents with dementia in the relevant homes. Can you just talk about the risk and how you manage that?
Sure. So we really view that there is risk with everything, but we really are of the belief that doing nothing is as much of a risk to our consumers as doing this. And so in saying that, we weren't reckless. We were really sensible about how we went about this and did what we did to mitigate the risk. We installed induction cooktops, so as soon as the stove is off, there is no hot surface. We have safety switches, and where there are high-risk utensils, they are stored away and locked away, and it's separate to the rest of the kitchen. We consider the risks and built in ways to mitigate them when we were planning and building the kitchens themselves. And some of the ways we have mitigated these is having lockable drawers for high-risk items, for example, like knives, toasters, where we can put those things away. We also have the ability to turn off cooktops in a more permanent position, and so they overnight that those cooktops cannot be turned on. So we've been quite specific about what we've done, but again, what we said and what we really believed is if we did nothing, that is just as much of a risk as doing, installing these kitchens. And really what we have seen is in the home style kitchen, in one of our dementia areas, we've actually had a consumer who would never sit to eat. Never sat. He paced all the time. He fed himself as he was walking around. He now sits and eats. And we just think that all of the risks that are out there with a home-style kitchen is really outweighed by those types of benefits. And again, we've seen anecdotally lots of improvements in our clinical indicators. And so we believe that taking this risk and outweighing it against not doing it, we've come up with our answer, and we're very comfortable with that this is worth the risk.
Thanks, Sharon. Yes, and speaking as a geriatrician, capabilities that are retained by people unexpectedly long are things that they've had a long familiarity with, and doing things around the kitchen and being careful around things that are familiar to them as a risk that they've known all their lives is certainly, that doesn't really surprise me. It's so encouraging to hear that you're noticing changes in weight loss, falls, psychotropic medicine usage, behaviours, and of course quality of life, and really be good to hear if you do get a chance to review your data more closely to hear that. I'm sure that everyone here today has taken away some things that they can do, and there are many things that we haven't even discussed that can make a little difference. I was hearing only last week about a carer who went to the $2 shop and bought some really bright, cheerful placemats, and for the whole week all the residents were saying, "Oh, doesn't it look beautiful in here? Isn't it lovely? Oh, aren't these nice?" And it just altered the tone for such a small investment and thought. Janet, I'll leave it at that because I know that there will be questions, but thank you so much, both of you, for sharing your story with us.
Oh, thank you, Melanie. And let me echo your thanks to Michael and Sharon. You've really treated us today, and I am quite sure that everyone online has been jotting down notes or making mental notes as to the sort of things they might want to discuss with others and follow up more closely. As the introduction to the question and answer session, because we do have some questions and I want to get to them, but perhaps, Michael, can I just invite you to summarise what particularly is required to engender this changed approach to food, nutrition and the dining experience? You've been on a journey, and you'll be the first to say that you've still got some way to go, that you'll never be satisfied with where you are, but that's actually about managing change. So how would you distill that for the webinar participants?
100%. And I think, what's really important, and it's a bit of a motto at Whiddon, is don't allow risk to be the excuse to do nothing. And I'm not from aged care. I am now. I've been here 5 years. But previous to this, I was not in aged care. And for me, it was really interesting to see the way that we approached risk. And obviously, you have people's lives in your hands, so you've got to be very conscious of that. But what I found was that it was a bit of an excuse, and we needed to move on from that. challenging the process is really, really important. And I think, you know, when we started talking about the all-day dining menu, it was very much how it wouldn't work. And that mindset needs to change. It can't be about why it's not going to. It has to be about how you have to make it work. Get residents involved. Why we cook food that residents don't want to eat just does not make sense. We should be asking them and getting them involved. And look at your dining rooms. It's not rocket science. If your dining room doesn't look inviting and it's not somewhere you would want to eat, then why would they want to eat there? Sell the benefits around what you're trying to do, and don't allow negativity to be the reason not to do it. And try things. We've tried many things. Most have failed, but the ones that have been successful have made a massive change. So that would be my tips.
Okay. Well done. Let me go to questions, and thank you to everyone who's put them in. We've got a very fertile ground here to cover in a short space of time. We'll see how many we can address. Michael, unsurprisingly, a number of questions do go to the issue that you were tackling and that Sharon also mentioned, this notion of risk. So Ian has asked, in relation to the cooking club, for example, how does this fit into your food safety program? And then there's another question from Manish, who is asking, with residents helping with food preparation and wiping down benches and so on, how do you manage the infection control implications? So rather than drill down to the specifics, can you just share with us again your approach to risk mitigation, risk management?
Yeah, look, so when it comes to food safety programs, obviously we all have them. Our food safety program is very robust around what our processes are, especially around kill points and around how we would interact with our residents. So, for example, our chefs are part of the cooking club, so they make sure and facilitate the actual club with the residents. So it's not residents left by themselves to be doing preparation. We give our residents chef hats, and we obviously implement really strict hand washing procedures prior to it. And anything that's going to be either uncooked or cooked, depending on what that is whether or not we use gloves. But hand washing is a huge one. And training support step by step for those chefs, which is done by our group executive chef. He's done a lot of training with all of our chefs around how you get your residents involved. But cooking is really the main kill step, as we know, for food safety in all of our homes. So as long as we are still following our food safety program and all of the protocols around that, there is no issue with having residents involved.
Okay. I have a question, a very similar question from Kylie and from Brandon, and it's in relation to dietitian reviews of menus. And they're wondering how you incorporate that in your approach to food nutrition and the dining experience.
Yeah.
I'm not sure. Michael? Yeah.
Yes. Yeah. So like I said earlier, we still have a menu that we propose to our residents, and then we review it with them, and we go over the fortnight and we chop and change. Our initial menu is reviewed by a dietitian, and we have a very high protein driven menu on purpose. And they review it and they tell us and they give us all of the ratings to make sure that our menu is very sound from a dietitian's perspective. What we say to our team is that if that menu is to change by more than 25%, then we need to just review and make sure that it still sits from a dietitian's perspective as adequate. Now, the great news is that as we've learnt over the years what our residents are wanting, we are already incorporating that in our menu. So we're seeing minimal change when we're actually doing our menu reviews with residents. But what we do see a lot change is things like sauces or the cut of meat. But generally, the actual menu item doesn't change too much. Okay.
Another question here. I'm the chef. I don't interact much with the board, who give me a very tight budget for food, and costs are going up. How can I convince the board to take a chance on spending more money? Now, the question is on a new kitchen, but I expect that the extended version of the question is in undertaking some of these significant change programs. If the chef is convinced, how can this message be communicated through to the board in a compelling way, in the way that you've shared it with today?
So personally, I would look at a few things first, how much you are spending on supplements and how much waste you have. And so if you can look at those two items, straight away, you will probably see that there's areas for improvement in those two areas. If you're having a high level of falls and wandering, these can be opportunities, for improvement as well. So, for example, where there's falls, there's often, unfortunately, injuries, and we end up with wounds. We end up with, compromised skin integrity, where consumers will end up needing more money spent. So, for example, if we end up with a frail person who has a pressure injury or has a chronic wound sustained from a fall, all the interventions that go into looking after that person cost a significant amount of money. And so if we can look for other ways to prevent that fall from happening in the first place, and to prevent that compromise in skin integrity, prevent the pressure injury, prevent the chronic wound that comes about as a result from an injury, we're going to save a lot of money anyway. And so I would start to look at those things first, and then once you build on that, there could be other opportunities for improvement.
Okay. One more question, two more actually. Michael or Sharon, not sure which. With the all-day menu, how do you ensure that residents get food that's nutritious and enough for the day? Are they on food charts? So how do you keep an eye on the whole when you are encouraging choice?
We would only have someone on a food chart if there's a clinical need. Yeah. And so, for example, if people's weight is not being maintained, we may consider a food chart then. But the food chart is really only driving the change. And so what we would use is that food chart to drive the change, and then we would cease the food chart, and then we would start continuing to monitor somebody's weight. But definitely, food charts, there are a place, but it's not the ultimate measure. But so, once we are confident that people are, enjoying their food, we're hearing from them, we're seeing that their weight stabilizes, that would be our measure in terms of how much they're enjoying the menu, and then, of course, the 24-hour dining menu.
And just for clarity, sorry to jump in, just for clarity, the all-day dining menu is not a substitute for the daily menu. It is on top of our menu. So our normal regular breakfast, morning tea, lunch, afternoon tea, dinner, supper is still there. And then we have all-day dining menu available on top of that.
Yeah, brilliant. Okay, this is a question without notice. I think one or other of you can field it. We have Marcus has asked whether they can come and visit. They're really impressed with all that you've said.
100%.
And they were wondering whether they could get in touch and arrange for a time to come have a look at what you're doing, how you've managed the change, how you manage the risk, because everyone is interested in that as well, but also the benefits that you're realising.
No problem.
Can I give
Absolutely no problem. Happy for them to contact me. And we've got several homes throughout New South Wales that have the concept, so it doesn't have to be something coming to Sydney, and happy to show anybody who would like to see it.
Wonderful. Well, regrettably, that's all we have time for, and I'll do a quick wrap up. Thank you to Melanie as the leader of that conversation, and obviously to Michael and Sharon from Whiddon for all that you've shared with us. I think you have stimulated a lot of thinking, judging from the questions we've received. If people can stay online to complete the survey, we would really like to hear from you. If you've been prompted or inspired by anything you've heard, let us know, and certainly give us feedback on the webinar. We've also provided in the survey a link to a goal planning template, and you can find that also on our website, and it might assist you in planning for improving the food, nutrition and dining experience in your service. Also, again, send us through your stories, your case studies, your ideas. We want to assist in promulgating these more widely across the sector, and this is the best place for us to start. Thank you for all the questions. Those we didn't get to will be the subject of a Q&A sheet, which we'll publish on our website. Early next year, we'll have our next in the webinar series, which we're focusing on swallowing, and we'll give people advice as to when that's going to happen so you can sign up for it. And also we're running a series of parallel webinars on the aged care reforms more generally from a regulatory perspective. So keep an eye on our website, keep visiting it so that you are updated on what we have to offer and where you can get more information on anything which interests you and which will allow you to be a high-performing provider, because that's exactly what we want you to be, and I suspect you share that ambition. Thank you, everyone, for participating today, and see you later.